All right, everybody. Well, welcome to the National Fellow Online Lecture Series. We're super excited to have you guys here and joining us tonight. My name is Dr. Siobhan Statuta, and I'm really honored to be here tonight for a number of reasons. Number one, I think the topic that we're going to be discussing tonight is super timely and super valuable as well. So I'm going to try to adjust my camera just a hair. So this is the National Fellow Online Lecture Series. And let me just try to advance my slides. Okay, and tonight's topic is clearance for sport. I'm your moderator, Siobhan Statuta, and I'm really excited to introduce you in a few moments to our illustrious speaker, Daphne Scott. Before we do that though, just a plug, we have an upcoming lecture. It's going to be High Yield Medical Topics in the Training Room by Dr. Siobhan Statuta. And oh my goodness, that is me. It's going to be not next week, you guys. It's going to be in 2 weeks. So Wednesday, September 7th, be on the lookout for a reminder coming to you by email. But same time, 8:30 p.m. Eastern. Again, High Yield Medical Topics in the Training Room. Some goals of this online lecture series, for those of you who are new, is to serve as an adjunct to your individual programs, educational programming. In addition, we want to provide you fellows with direct access to educational experiences with experienced AMSSM members. And at times, we go outside of AMSSM to invite guest experts in a variety of formats. And then, of course, we were all fellows at one time. If you know, those of us who have become sports medicine physicians, this is also to assist you in your CAQ exam prep, because we all know that's in the back of our minds. All right, some rules regarding tonight's talk. Please mute your device's microphone and turn off your video. You can submit questions, and you're encouraged to do that through the chat function. You can include your name and program if you wish. You don't have to. The moderator, me, will ask the questions during the Q&A based on the questions you submit and based on the timing that we have. After the program, you'll see an evaluation link that's going to come across the chat line. Please take a moment or two to evaluate that. That helps us and it helps Dr. Scott as well. So thank you so much for doing that in advance. So without further ado, I get to introduce you to my friend, my colleague, Dr. Daphne Scott. Dr. Scott completed her residency in family medicine at the University of Washington, and then she later completed fellowship at the University of Arizona. Dr. Scott currently serves as Associate Chief Medical Diversity Officer and an Assistant Attending Physician on the Primary Care Sports Service at HSS, or the Hospital for Special Surgery in New York City. In her free time, she decides to offer some additional coverage. She serves as the head team physician for the Westchester Knicks, the NBA G League. She serves as assistant team physician for the New York Knicks, and she's head consulting orthopedic physician for UFC. So I know you guys are probably tired of hearing me talk, so without further delay, I'm going to pass the baton over to Dr. Scott to teach us a thing or two about clearance in sport. So
thank you so much. Let me start sharing my screen.
Perfect.
Let's see here. Okay, can you see my presenter slide, or the good slides? Perfect. Okay, let me just move the boxes with everyone's faces there over, and we can get started. So thank you so much, Dr. Statuta. And it's great to be with you all tonight as we talk about clearance for sport and review the pre-participation physical evaluation and other clearance-related topics. Let's see if my slides will advance. There we go. There are a couple of different ways to discuss clearance when it comes to sport. Most commonly, we think of pre-participation clearance and clearance after surgery or clearance after illness. For the purposes of tonight's talk, we will focus on the pre-participation clearance exam, and we'll look at the 5th edition of the PPE monograph, as well as clearance limitations, special considerations, and clearance for special populations. The pre-participation physical evaluation has long been used to determine medical eligibility for youth sports. The first PPE recommendations were published in 1992, and despite all this time, we do not have any outcomes-based data to support the ability of the PPE to reduce injury or illness. Over the years, however, the content of the PPE has been recommended, debated, and extensively reviewed, and medical societies have come together to continue to recognize the important role of the PPE in the care of athletes, with the most recent recommendations coming from the PPE-5, which we will discuss in detail tonight. The fifth edition of the PPE monograph was published by the American Academy of Pediatrics in 2019 and is the most comprehensive, up-to-date guidelines on the PPE, containing consensus recommendations from multiple stakeholder medical societies listed here, including our very own AMSSM. As per the writing group, this was a rigorous attempt to identify and outline evidence-based and expert opinion principles and practices in the examination and medical eligibility decision. It contains new recommendations regarding mental health in athletes and addresses certain groups, including female and transgendered athletes. The main goal of the PPE is to promote athlete health and safety by determining general physical and psychological health, evaluating for life-threatening or disabling conditions through the use of the personal and family history to search for red flags and use them as an opportunity to further investigate. Evaluating for conditions predisposing to injury or illness, providing an opportunity for discussion of health and lifestyle issues and engagement in discussion, and serving as an entry point into the healthcare system for adolescents without a medical home. Ideally, the PPE would be scheduled with the PCP in the setting of the primary medical home, where the PCP has access to medical records, can adjust treatment of chronic medical conditions, and can incorporate the exam into routine health supervision examinations. It should be performed well in advance of preseason practice to allow for time to evaluate, treat, or rehab any problem identified. Current PPE intervals at high school and college levels vary. At the high school level, intervals are arbitrary and based on state and organization requirements. At the college level, they are determined by the NC2A and other organizations. Typically, at the start of college, athletes will undergo comprehensive evaluation, but in subsequent years, that evaluation will be much more abbreviated with a focus on injuries or medical problems that have since occurred. The consensus of the writing group was that a comprehensive PPE should be performed every 2 to 3 years with the goal of integrating the PPE into the healthcare home. The thought is that this may allow a different focus for the evolving patient. Annual updates can focus on heart, head, heat injury, and mental health issues. And if needed, a problem-focused examination can be done if any concerns are detected in the history. Although the PPE often detects conditions that may predispose the athlete to injury or limit full participation, most athletes are cleared without significant abnormalities being noted. Research has shown that 5 to 15% of athletes undergoing PPEs require further evaluation before allowing participation. Disqualification is rare, with most individual PPE studies reporting that less than 3% of athletes are denied medical eligibility to participate. So the take-home message is that the goal of the PPE is not to disqualify the athlete. For the purposes of tonight's presentation, I decided to split the PPE up into sections. First, starting with the history and screening, then focusing on the physical exam, and finally reviewing clearance consideration in special populations. So let's get started with the history and the screening. The medical history is an important component of the PPE, and the history alone can detect up to 88% of general medical conditions and 67 to 75% of musculoskeletal conditions pertinent to sports participation. Providing history forms before evaluation allows the athlete and family time to complete an accurate medical history and to reduce errors. A parent or guardian should be involved in the completion of the form, as a study found that only about 19% of students' answers were in concordance with their parents' responses. The medical history should be reviewed twice, ideally in a private setting with both the athlete and the parent or guardian present, and along with the athlete for more sensitive questions when age and developmentally appropriate. Specifically, questions regarding mental health concerns or high-risk behaviors should be addressed when the athlete is alone. Also, ideally, one would provide confidential access to validated supplemental questionnaires such as the CRAFT tool, which we will review later. The PPE is an opportunity to review medication, supplements, and ergogenic aids. It also serves as a time to counsel athletes on potential risks and benefits and optimize the frequency and dosing of prescription medications to better control underlying illnesses during exercise. Many athletes may be hesitant to reveal the use of supplements or other ergogenic aids, so an open and inviting questioning style may help elicit an accurate history. Allergies and associated reactions can range from minor rhinitis or runny nose to life-threatening anaphylaxis. Minor allergic reactions, such as rhinitis, may influence performance and can be associated with asthma and exercise bronchospasm. If someone lists an allergy, a secondary question can be used to further evaluate, including, did this reaction involve swelling of your lips or tongue? Did it make it difficult for you to swallow, talk, or breathe? Have you ever needed medication, including an injectable medication, to treat an allergic reaction if someone answers positively to that first screening question? With regard to the cardiovascular history, these questions involve asking about the athlete and their family. Questions about the athlete will touch on syncope or passing out, chest pain or discomfort, heart palpitations, a history of heart problems, previous cardiac testing, and a history of seizure. Positive answers to these questions may prompt consideration for further evaluation to determine eligibility. Heart health questions about the family ask about death at an early age, typically before the age of 35, a history of genetic heart problems, or surgery to place a pacemaker or defibrillator before the age of 35. Again, positive answers to these questions may prompt consideration for further evaluation to determine eligibility. Moving on to the nervous system history. This is where one would ask about seizures, concussions, headaches, memory problems, and any peripheral neurologic symptoms after a hit or a fall. If there was a positive response, secondary questions may include, what can you tell me about your head injury or concussion? Have you ever had an unexplained seizure? Has anyone in your family had unexplained fainting, seizures, or near drowning? Do you have headaches with exercise? What can you tell me about symptoms in your arms or legs after a hit or a fall? Or have you had any tests or imaging for the problem? With regards to concussion, there are two primary considerations for medical eligibility when an athlete has a history of a sport-related concussion that's noted during the PPE. First, the most recent concussion must be completely resolved. And second, it's important to remember that a prior concussion places an individual at a higher risk for future sports-related concussion. A history of sports-related concussion should trigger secondary related questions, including the number, frequency, severity, and recovery of concussion, and include what treatment was needed and the presence of any lasting mood, learning, attention, sleep, or migraine disorders. The NC2A recommends a one-time pre-participation baseline concussion assessment for all college varsity student athletes, and that should include, but it's not limited to, brain injury or brain concussion history, symptom evaluation, cognitive assessment, and balance evaluation. With regards to headache history, we know that frequent headaches can be caused or worsened by intense or prolonged physical activity and can interfere with sports participation. Providers should consider primary and secondary reasons for headaches, including sport-specific causes. An athlete with a primary exertion or effort headache must also be asked about prior or current concussion and head injury, because we know that following a concussion, an athlete may continue to have headaches with exertion related to that head injury. With regards to surgery, it's important to review any previous surgery that an athlete has had. Secondary questions after a positive response may include the type and timing of surgery. In the case of recent surgery, it is important to find out what the athlete has done as a part of the rehabilitation process and if they have been fully cleared to return to sport. The most common pulmonary issues for athletes are intermittent persistent asthma, exercise-induced asthma, or bronchospasm. Athletes with exercise-induced asthma or bronchospasm often report cough, wheeze, dyspnea, chest tightness, or shortness of breath with exercise. In athletes with this history, it's important to determine the severity of asthma and the current level of control. In athletes who do not have a prior history of asthma but report respiratory symptoms during exercise, it's helpful to determine at what point during the exercise these symptoms occur, whether they're more common during one season or sport, and if the athlete can distinguish whether the symptoms occur during inspiration or expiration. Potential secondary questions to a positive response include asking about inhaler and other medication use and triggers. Other pertinent medical history obtained during the PPE can include asking about a medical history, specifically a recent mono diagnosis in the past month, also reviewing immunization status, which has become especially important in light of the current COVID-19 pandemic. Other medical history obtained can include asking about a history of sickle cell trait and other dermatologic conditions, the presence of a missing organ, such as an eye, kidney, testicle, or spleen, and following up with questions about the GI and G systems to further elucidate if there could be problems such as a symptomatic hernia or a testicular issue. We know that heat illness adversely affects athletic performance and can be associated with severe morbidity and death, and is a particular concern for athletes practicing and competing in hot environments, especially when they have occlusive equipment such as football uniforms on. The PPE should include specific questions regarding possible risk factors, including prior heat illness, the associated environment, acclimatization status, equipment, uniforms, fluid intake, weight changes, and medication and supplement use. It's important to remember that the pre-participation evaluation is an opportunity for anticipatory guidance, and athletes with a documented history of heat stroke or heat-related rhabdo merit further investigation. With regards to abnormal vision, this is among the most frequently reported finding during the PPE. Secondary questions for a positive response to a history of problems with eyes or vision include asking about eye injuries or surgery, the use of glasses or contacts, and protective eyewear, as well as the timing of the last eye examination. Musculoskeletal injuries and concerns are the most common problems that team physician and healthcare professionals see in the office, in the athletic training facility, and during the PPE. First and most important step in the evaluation is to determine medical eligibility. In determining medical eligibility is to take a focused musculoskeletal history. A thorough review of this history and examination of previously injured areas may improve detection of musculoskeletal conditions during the PPE. Many athletes are affected by underlying mental health conditions, and mental health is increasingly recognized as a major issue for athletes. Screening is an important part of the history with several tools available. As a provider performing a PPE, awareness of available resources and developing a multidisciplinary treatment plan are essential. The PHQ-9 is included in the monograph, and it combines depression and anxiety screenings into a short question format. It asks for how often symptoms are noted over the last 2 weeks. Choices can include not at all, several days, more than half days, or nearly every day scored with 0, 1, 2, or 3 respectively. The total scoring ranges from 0 to 12, with categories of psychological distress ranging from none to severe. The anxiety subscale is the sum of items of 1 and 2, and the depression subscale is the sum of the items of 3 and 4. A score of 3 or greater is considered positive on each of the subscale for screening purposes, and the physician can determine whether the athlete needs to be evaluated by a mental health professional depending on their scoring. The PPE can also be used as an opportunity to screen for and educate patients on bullying, hazing, sexual abuse, and sleep disorders. Substance use disorders are prevalent among adolescents and young adults, including athletes at all levels. Substances used by athletes may include mood modulators, alcohol, cocaine, medications to treat symptoms of illness or injury such as opiates, legal or illegal medications to help with healing and performance, including steroids and stimulants. The age of traditional college students, 18 to 24, also coincides with peak years for onset of common mental health problems, and this may be exacerbated by the use of alcohol and other drugs. The CRAFT 2.0 tool is a health screening tool designed to identify substance use and substance-related driving risk and disorder among youths ages 12 to 21 and can be used as a part of the exam. CRAFT is an acronym for the 6 key words in the second section of the assessment: car, relax, alone, forget, family, friends in trouble. The tool is split into two parts. Part A asks about substance use in the past 12 months, while Part B asks about high-risk behaviors such as driving high, using drugs to relax, using alcohol alone, being told by friends or family to cut down, and a history of getting into trouble while using alcohol or drugs. 2 or more yes answers suggest a serious problem and a need for further assessment. Brief counseling talking points include reviewing screening results. For each yes response, asking, can you tell me a little bit more about that? Recommending someone not to use, maybe saying as your doctor, my recommendation would not be to use this because it can harm your developing brain, interfere with learning and memory, and put you in dangerous situations. Risk counseling, talking with them about the fact that motor vehicle crashes are the leading cause of death for young people, and potentially providing a contract for life to take home and discuss with parents, guardians, or friends to create a plan for safe rides for getting home. You can elicit self-motivational statements. So you can ask someone why you don't drink or use drugs, or if someone asks you why you don't drink or use drugs, what would you say to them? And last, reinforcing. I believe you have what it takes to keep alcohol and drugs from getting in the way of achieving your goals. If indicated, the CRAFT 2.0 can be followed up with the 18-item mental health screening form, which is a useful screening tool for identifying mental health problems in individuals who depend on alcohol and other drugs. It is important to remember that the female athlete triad, or the triad and relative energy deficiency in sport, REDS, are syndromes that occur when energy expenditure is disproportionately high relative to caloric intake. Screening for the triad and for RED-S is challenging because many features are not readily apparent until they have progressed to serious concerns. The PPE-5 has an increased focus on specific medical and musculoskeletal concerns for the female athlete, including bone and joint questions looking for a history of bone stress injuries, neurologic conditions, as we know that female athletes have higher rates of concussion and post-concussion syndrome, nutritional concerns, and menstrual history. Here are the screening and secondary questions for nutritional concerns and menstrual history. These include questions about weight concerns, dieting, and eating disorders, as well as menstrual periods in the last 12 months, hormone use, and dysmenorrhea. Now that we made it through the history and screening, let's move on to the physical exam. Expert consensus recommends a structured, limited physical examination, but evidence is lacking for performing any other routine screening test in asymptomatic athletes. Vital signs to be obtained during the PPE include height, weight, heart rate, blood pressure, and vision acuity. Elevated blood pressure and visual acuity problems are among the most common abnormalities noted during the exam portion of the PPE. With regards to an elevated blood pressure, if you find this, it's important to check and ensure that the blood pressure cuff is properly fitted. If the blood pressure is initially elevated, the athlete should lie quietly for about 5 to 10 minutes before repeat measurement. If it's still elevated, additional visits will be required to establish a diagnosis, treatment plan, and medical eligibility for a presumptive diagnosis of hypertension. Additional components of the exam include noting pupil size and other pertinent characteristics. High arch palate, looking for stigmata of Marfan syndrome. This here is a picture of Max Scherzer, who's now with the New York Mets. He has a blue right eye and a brown left eye, which would be important to note on exam if you were seeing him for a PPE. Visual acuity of 20/40 or better, and at least one eye is considered to provide good vision. An athlete is considered functionally one-eyed or monocular when the best corrected visual acuity in one eye is less than 20/40. Athletes who have had an eye injury or surgery may have a globe that is weakened and therefore may be more susceptible. These athletes should be referred to an ophthalmologist for complete evaluation and medical eligibility determination. Pulmonary evaluation of the anterior and posterior chest should be done in a quiet room with the patient in the seated position using breaths that are deeper than those of normal breathing. Breath sounds should be clear and equal bilaterally. Wheezing, rubs, prolonged expiratory phase, and cough with forced expiration require evaluation for a cause and a treatment plan. You may also note throughout the exam allergy signs such as allergic shiners, nasal polyps, pharyngeal cobblestoning, watery or bloodshot eyes. The abdominal exam should be performed supine with exposure of the ASIS to ensure adequate inspection and palpation of all 4 quadrants. For the genitalia exam, a female exam is not part of the PPE, and any indication to perform a male exam is based on history, where you'd be looking for evidence of something like an undescended testicle, evaluation of groin pain or bulges, or testicular masses, keeping in mind that testicular cancer is the leading cause of deaths in men 15 to 35 years of age. The objective of the dermatology exam is to identify skin infections, and a thorough skin survey should be performed with particular attention to an area that may come in contact with another competitor or equipment. This is particularly important for wrestlers and football players. The provider should also evaluate for signs of acne, sun damage, dermatitis, and marks of illicit drug use or cutting. With regards to the cardiovascular exam, the AHA recommends that the PPE includes auscultation for heart murmurs, palpitation of femoral pulses to exclude coarctation of the aorta, examination for physical stigmata of Marfan syndrome, and brachial artery blood pressure taken in the sitting position. Auscultation should be performed with the patient in both the supine and standing positions or with Valsalva maneuver, specifically to identify murmurs of the dynamic left ventricular outflow tract obstruction to try and evaluate for those murmurs that might be, that are unlikely to be innocent. When evaluating for stigmata of Marfan syndrome, it is important to remember that exam findings include highly variable features which typically appear in adolescence and young adulthood. The physical examination should focus on hypermobility of the wrist or thumb or both, chest wall deformities, murmur associated with mitral valve prolapse, hindfoot deformities. For asymptomatic athletes with no previous injury or notable concerns on history, a screening musculoskeletal exam can be used. If the athlete, however, has a previous injury or other signs or symptoms, the screening exam should be supplemented with relevant elements of an anatomic site-specific examination, like a more specific exam for the knee if there were knee issues. Things to look out for include pain and tenderness, effusion, atrophy, limitations in strength or range of motion, or an obvious deformity. So quickly reviewing the screening exam, otherwise known as a 2-minute screening exam, we'll go through some of these. So you can start by having the athlete face you and look for general habitus and evaluate for deformities such as AC joint deformity. Have the athlete look at the ceiling, the floor, over their shoulders, and touch their ears to the shoulder to evaluate cervical spine motion. You can do resisted shoulder shrug to evaluate trapezius strength, resisted abduction of shoulders to test deltoid strength, full rotation of arms to evaluate shoulder motion, flexion of elbows and supination and pronation of wrist to evaluate elbow and wrist motion, spread fingers and make fists to evaluate hand and finger motion and strength, as well as to evaluate for deformities, contract and relax quadriceps to look for symmetry and knee effusions, duck walk to evaluate hip, knee, and ankle motion. With the back to the examiner, you can evaluate for shoulder symmetry, scoliosis, have them do back extension to evaluate for motion. And then with knees straight, they can bend over, touch their toes to evaluate, again, for scoliosis, motion, and hamstring tightness. Lastly, you can have them raise onto toes and heels to evaluate calf symmetry and leg strength. So now that we've made it through the exam, we now need to figure out if an athlete is cleared to participate. With regard to determining clearance or medical eligibility, there are specific categories. So an athlete can be medically eligible for all sports without restriction. They can be medically eligible for all sports without restriction with recommendations for further evaluation of treatment. They can be medically eligible for certain sports, not medically eligible pending further evaluation, or not medically eligible for any sports. I will spend the rest of the time focusing on special considerations when it comes to clearance and times when limitation at the time of PPE may be considered. Clearance considerations after surgery. So following surgical procedures, the surgical team should determine the athlete readiness for return to physical activity and participation in specific sports. A progressive, stepwise return to sport based on the type of surgery, body parts involved, and general health of the athlete is recommended. Simple, uncomplicated procedures such as an appendectomy usually result in a quick and full recovery in a predictable time frame and with limited impact on future athletic participation. Higher risk procedures may result in longer recovery times and may result in potential restrictions from future participation. Athletes with persistent or easily induced fatigue, continued weight loss, insufficient rehabilitation, they may be at higher risk for recurrent or new injury, and medical eligibility may be deferred until they are fully recovered. Any ongoing use of post-operative medications, including opioid pain medication, which may risk dependence or impair cognitive function, stamina, and reaction time, suggests that an athlete is not ready for return to sport. While I would like to review all of the specific medical issues given our time limitations, I'm going to focus on these clearance considerations. As previously discussed, if blood pressure remains elevated, additional visits will be required to establish a diagnosis, treatment plan, and medical eligibility. All children and adolescents diagnosed as having hypertension require careful evaluation for secondary causes of hypertension and target organ disease. Athletes found to have stage 2 hypertension or findings of end organ damage should not be allowed to participate in any competitive sport until their blood pressure is further evaluated, treated, and under control, at which time medical eligibility can be reevaluated. In the setting of the COVID-19 pandemic, I did want to touch on this. So if an athlete has had COVID-19, additional history questions during the PPE should clarify when, what symptoms, and if an athlete is experiencing any new symptoms, especially chest pain. This figure is from the most recent guidelines published in February this year regarding COVID-19. For an athlete who is asymptomatic or only had very mild symptoms, they do not require formal medical evaluation or cardiac testing. Athletes with specific concerns should check in with a clinician. And in the case of recent illness, athletes should be 3 days from symptom onset or positive test before beginning an exercise program. With regards to moderate symptoms, an athlete who had a remote infection greater than 3 months ago, but never received workup and has since returned to full activity without any symptoms does not need a medical evaluation of additional cardiac testing. With regards to moderate symptoms in case of recent illness, athletes who have moderate symptoms defined as fever, chills, flu-like syndrome for greater than 2 days, or initial cardiopulmonary symptoms, chest pain, dyspnea, palpitations should be evaluated by a clinician. Cardiac testing is recommended for these athletes, especially during the acute phase of the infection. Athletes should be 5 days from symptom onset, and moderate symptoms should be fully resolved before starting an exercise progression. Athletes with severe symptoms that required hospitalization should undergo formal evaluation with a cardiovascular specialist before starting an exercise progression. Athletes with cardiopulmonary symptoms upon returning to exercise should undergo additional cardiac testing if not already performed, including ECG, echo, and troponins. They should also have cardiology consultation and cardiac MRI and other studies as indicated. With regards to cardiovascular symptoms and abnormalities, there are no outcomes-based studies that have demonstrated that the PPE is effective in preventing or detecting the rare instance of an athlete at risk for sudden cardiac death. However, many athlete abnormalities have been found during evaluations. So athletes that are identified with cardiovascular symptoms or signs require a thorough cardiovascular evaluation to exclude underlying heart disease before they are allowed to participate in vigorous physical activity. Activity recommendations involving temporary or permanent sports disqualification or restrictions should be made in consultation with a cardiologist. With regards to seizures, although they're not very common, mostly in part because patients with seizure disorders may be discouraged from participating in strenuous exercise and team sports for fear of exacerbating their disorder, we know that those with well-controlled seizure disorders can participate in collision and contact sports without affecting seizure frequency. However, new onset seizures or seizures occurring after head injury require a thorough medical evaluation, and seizure control needs to be there before resuming sport participation. Water, aerial sports, archery, riflery, strength training, weightlifting, powerlifting, and sports involving heights can present unique challenges for athletes with seizures. Water sports carry the risk of drowning. Aerial sports carry the risk of falls. Limitations may be indicated for some athletes and should be discussed with the athlete and parents and guardians. Athletes with seizure disorders must never swim, dive, or train in water alone, and coaches should be informed so they are aware of risks. With regards to concussions, the absolute number of concussions an individual can sustain and continue to participate in contact sports has not been identified, but clinicians should be aware of the potential for long-term consequences from multiple subconcussive impacts. There are no evidence-based guidelines for disqualifying or retiring an athlete from his or her sport after concussion, although there are some expert opinion publications that can provide considerations for limiting medical eligibility. Any athlete should be referred to a specialist with expertise in sports-related concussion when contemplating retire from a specific sport. With regards to diabetes, we know that exercise and strength training are beneficial for patients with diabetes. Adequate glycemic control before exercise is important because poor glycemic control and poor understanding of the disease process can put a diabetic athlete at risk for dangerous hyper or hypoglycemia. Athletes with diabetes should be monitored by a clinician with expertise in management. This here is a picture of Kate Hall, a sprinter and jumper who made national news in 2019 by trying to be the first athlete to make the Olympics with type 1 diabetes. Sports such as scuba diving, skydiving, and rock climbing are considered especially high risk for patients with diabetes because of the consequences of a hypoglycemic episode during these events. Athletes should be educated on the risk of hypoglycemia during and after exercise, and there should be a written action plan in place with recommendations for blood glucose monitoring before, during, and after exercises, recommendations for changes in athletic participation if needed, and recommendations for insulin adjustments and carbohydrate intake. Coaches and on-site medical providers such as athletic trainers should be competent in delivering emergency diabetic medications. With regards to the GI system, abdominal abnormalities should be further evaluated before determining medical eligibility. Specifically, participation in all sports for athletes with organomegaly, such as the hepatomegaly, should be avoided until resolved. An athlete with an asymptomatic inguinal canal hernia may participate in all sports. A symptomatic inguinal hernia, though, may limit their ability to participate and should be evaluated for surgical intervention. With regards to testicular disorders, a single testicle is usually medically eligible. A cup is suggested for high-risk sports. It is important that athletes be informed of risk for injury or loss, and that a cup may reduce injury but does not guarantee complete protection. In the case of an undescended testicle, the athlete should be referred for evaluation and informed of the increased risk of testicular cancer if not previously done. If they have been previously evaluated and cleared, eligibility would be the same as with a single testicle. The absence of a paired organ does not disqualify a patient for participation. Testicle, kidney, ovary, and eye, usually protective equipment is typically recommended. As previously discussed, a cup for an athlete with one testicle, a flak jacket for an athlete with a solitary kidney. Ovarian injury is unlikely, and therefore there are no restrictions for female athletes with only one ovary. With regards to vision, athletes with a history of globe injury or who are functionally one-eyed must undergo further evaluation by an ophthalmologist, and this is recommended prior to clearance to participate in sport. An athlete, parents or guardian, the coach, sorry, did someone have a question? Okay. An athlete, parents or guardian, the coach, and school administrators, if necessary, must understand the degree of risk of injury with and without protection to the better eye, the level of protection available for the better eye, the serious long-term consequences if injury to the better eye were to recur. If, after discussion, a functionally one-eyed athlete still wishes to participate, appropriate eyewear should be used during participation. It should be noted that some athletes may choose not to use protective eyewear despite risks and recommendations. Athletes with a history of globe injury or who are functionally one-eyed must wear protective eyewear with these standards. So usually approved lenses made of polycarbonate. They should wear them even in non-contact and low-risk sport. So for example, in football, an athlete would use polycarbonate eye shield attached to the helmet mounted wire face mask. And in baseball or basketball, they would use sport goggles at all times. Sports in which one cannot effectively protect the eye are contraindicated for functionally one-eyed athletes. These include boxing, wrestling, and full contact martial arts. With regards to sickle cell trait and disease, we know that acute exertional rhabdo is associated with sickle cell trait and is a leading cause of atraumatic death in athletes, behind only sudden cardiac death and exertional heat stroke. Sickle cell disease in athletes has been relatively unexplored, but similar recommendations regarding training are in place. There are no contraindication to participation in sport for athletes with sickle cell trait or disease, but it's important to remember that intense exertional activity in hot or humid or high altitude environments may lead to exertional sickling, which can cause vaso-occlusion and ischemia. Early recognition of an athlete with sickling collapse may prevent permanent end organ damage and death. Exertional sickling episodes may be prevented by modifying practice and conditioning. This here is a 2021 article in one of my former basketball athletes, Billy Garrett, who has successfully played at high levels with sickle cell disease. There was a recent update for sickle cell screening at the NC2A level. Effective August 1st, 2022, student athletes in their initial season of eligibility and currently enrolled students no longer have the option to sign a waiver declining confirmation of sickle cell trait status. So our last section will review clearance consideration for special populations. Athletes with oligomenorrhea or amenorrhea may usually be allowed to participate while undergoing further evaluation. If sports participation would cause serious harm to the athlete's health or compromise appropriate treatment of the syndrome, limitation or disqualification may need to be considered. Treatment of the triad and REDS can be complex, involving a multidisciplinary team of health professionals. We know that athletes with disability get similar benefit from sports participation, including increased exercise, endurance, cardiovascular function, muscle strength, flexibility, balance, and motor skills, as well as improved self-esteem, reduced anxiety and depression, and satisfaction from participation in competition. There are also other benefits that are unique to athletes with disabilities, including lower likelihood of hospitalization, fewer pressure ulcers, and improved proprioception, as well as increased proficiency using prosthetic devices. The PPE for athletes with a disability includes similar components as athletes without a disability. It may require closer examination of specific symptoms. To determine medical eligibility, it's ideal to use a multidisciplinary approach with the athlete's medical specialists and service providers available to help assess medical condition, functional abilities, and demands of the sport. The Special Olympics requires a PPE for all athletes before participation. It's a similar medical history with the exception of sections on neurological symptoms for spinal cord compression and atlantoaxial instability. The athlete and the provider must document findings of spinal cord compression and instability, and additional workup may be needed depending on exam findings. Medical eligibility for sports participation should follow the same principles used for athletes with no disability, with an emphasis on inclusion and safe participation. Many conditions will not permanently preclude an athlete from participating, but may require further evaluation, treatment, or rehab. Some exceptions for limitations. In athletes with symptomatic atlantoaxial instability, they should be restricted from sports that require excessive neck flexion or extension or have risk for hard falls or landings. Pressure sores or ulcers may temporarily preclude full participation until the condition has resolved and the mechanical pressure point can be modified. With regards to transgender athletes, the policy on sports participation by transgender athletes has been controversial and continues to evolve at all levels. The process for approving transgender athletes for competition is rapidly changing and will continue to evolve. At the high school level, the matter is addressed at the state and community levels. The NC2A has a transgender student athlete participation policy, which was recently updated. So at its January 19, 2022 meeting, the NC2A Board of Governors updated their transgender student athlete participation policy. The new policy aligns transgender student athlete participation with the Olympic movement, resulting in a sport-by-sport approach, which hopes to preserve opportunity for transgender student athletes while balancing fairness, inclusion, and safety for all who compete. So, like the U.S. Olympic and Paralympic committees, the updated policy calls for transgender student athlete participation for each sport to be determined by the NGB of that sport. If there's no NGB policy for a sport, it would be determined by policy for that sport's international federation. The policy went into effect immediately, and there are 3 phases of the implementation. The third phase for full implementation is due to start in 2023-24. Given all that surrounds transgender athletes, ideally prior to the PPE, a safe and supportive relationship has been established between the athlete and the provider. Remember that it's important to address patients by their preferred pronoun or gender. Mental health screening and guidance should be thoroughly discussed, as it is with all athletes, and assumptions should not be made that any concerns are secondary to being transgender. Clinicians should become aware of regulations from local sports governing bodies to help transgender athletes navigate participation and advocate for themselves within these systems. Lastly, it's important to remember that when a condition is identified that may restrict an athlete's medical eligibility for participation, consultation with a specialist is typically warranted. If it is determined that there is risk to participation, shared decision-making should occur, meaning there should be a discussion among the athlete's family or guardian, and an interdisciplinary healthcare team about the risks and benefits of participation. It may be appropriate to consider an alternative activity or role that the athlete can participate in as allowed. Athletes should also be monitored and provided with the appropriate emotional support. So in summary, physicians and other healthcare professionals can use the PPE as an opportunity to enhance safe sports participation and promote healthy lifestyles. The PPE should be done well before the start of the season and as a part of routine health screening examinations by the PCP. The 5th edition of the PPE monograph updated the content of the body systems with a focus on screening, enhanced content from female athletes and athletes with a disability, and provided new recommendations on mental health and the transgender athlete. Here are some future research and knowledge gaps out there. So, should the PPE be required for sports participation given the lack of evidence to demonstrate overall effectiveness? Can we look at patterns of sport-related morbidity and mortality before and after mandated PPEs? Can we look at a systematic study of the history of questions? What would happen with an electronic version of the PPE? Could we keep better data? What is the optimal timing and frequency of the PPE? And should we have uniform standards for governing youth sports participation? So with that, I will go to questions. Let me stop sharing.
Daphne, thank you for that. That was awesome. I really, really appreciate that. I have a question for you that came up in the chat, and that is, in regards to Red S or Reds, what follow-up questions do you ask athletes that you have a concern for Reds, and how do you clear them? Do you require them to follow up first? How do you manage that situation?
So that's a good question. I think really trying to figure out what symptoms they're having, specific fatigue, symptoms they're having with regards to training, that sort of thing. Those are going to be questions you want to ask about. You also want to ask about diet, kind of what they're taking in. As I said, so patients who have either amenorrhea or issues like that, you can still allow them to participate while you're doing the workup. Now, if you have someone who has, I would say, they have an active stress fracture or really severe problems or severe disease, then you are going to limit that person. But, if it's something that you're just not quite sure and you need a little bit more of the workup, then you can allow them to continue to participate. So hopefully that answers that question.
I think it does. Personally, I have a question for you regarding that, but taking it one step further. The male athlete triad, how do you address that? Have you noticed the change in your own clinical practice in the last few years now that more and more information is coming out about it?
I mean, I think the big thing for me is just really talking with my male athletes. I mean, I take care of male basketball players and just talking with them about, any symptoms that they might be having. I think one of the biggest things, and we talked about this, ideally, people be doing their PPE with a PCP or someone that they know. When in the G League, it's really transient for me. So personally, as I have athletes that are kind of coming and going, when I meet them, really trying to just establish that that rapport and talking with them about my potential worries if they are dealing with something that makes me concerned about the male triad, and other issues, and kind of talking with them about why I'm concerned, and kind of just putting a little bug in their ear just to keep an eye out for things. And I have had some that have come back to me with specific concerns. So
yeah. So knowing the audience here is primarily made up of fellows. When you're thinking about your own bedside manner, what do you think makes you successful in having these difficult conversations on some very uncomfortable, personal conversations that you may be delving into immediately after meeting an athlete for the first time?
Yeah, no. Again, going back to establishing that rapport, I think it's so important. Really showing that you are concerned about an athlete. And what I've learned is explaining, again, going back and explaining why you are concerned about that athlete. Sports is only one area of their life, but I've said, I don't know how many times I've said, yeah, this is you now. I'm thinking about you at age 45, age 50, age 70, age 80, really putting out there that you're concerned about them and their health. I think also just making yourself available. Again, someone may not want to talk about something right then and there as you bring it up, but giving someone your cell phone number, saying if you're a fellow, you're in the training room, hey, if you see me in the training room and you want to talk about this more, let me know. If you want more information, just really being open. And then it just kind of goes back to learning how to explain things in layman's terms, right? Like when we're talking to athletes, just putting it into terms that work for them. I think that goes a long way.
Right. I think somebody taught me, and I think this is talked about in sports medicine quite a bit. It's the 3 A's of sports medicine, isn't it? It's affability, availability, and ability is last. So it's the ability to relate to these individuals on a personal basis and building that trust. So I definitely, I like the way you stated that, and just keeping that open door policy. The whole sharing of the cell phone, that makes me squeam a little bit, but
I will tell you, I'm the worst of it. All my guys have my cell phone. When I was a fellow in Arizona, I feel like every athletic trainer I met got my cell phone number. I mean, it's a bad habit that I have. So,
but it's also providing times and ways to reach you, reaching your colleagues, reaching everybody around, because it's not just you, right? As the team physician, it's the team that you surround yourself with. So it's, the athletes have their entourage, but we as sports medicine providers have our entourage, and we lean and rely on other people. So going back to the question about REDS or female or male athlete triad, it's the burden or the decision for safety isn't just on one person. You need to tap your colleagues, your sports psychologists, your registered dietitians, and talk about it as a team. Absolutely. What is going to be best, right?
Absolutely. And I mentioned that it's a multidisciplinary approach when you're addressing that, and it has to be. I mean, to go at it on your own doesn't work. And right. we know that. So
wonderful.
I know Andy just reminded me of the other 3 questions, so we can go ahead and do those. So guys, Andy is gonna put these out there and you can answer them. But the first question will be, which one of the following is not a goal of the pre-participation physical exam? So the options are: determine general physical and psychological health, evaluate for life-threatening or disabling conditions, disqualify athletes for conditions predisposing to injury or illness, provide an opportunity for discussion of health and lifestyle issues, or serve as an entry point into a healthcare system for adolescents without a healthcare or medical home. So give everyone a little bit.
The audience, feel free to answer. It is anonymous, and
Yes.
then just select one, hit submit, and then we'll get a recording after to see how people answered.
Perfect. And then we can go on to the second question. Here we go. Here's the poll for that first question, or the answers for the first question. Thanks, people, for answering. So for that second question, so which one of the following is incorrect regarding setting, timing, and frequency of the pre-participation physical exam? Ideally, the PPE would be scheduled with a PCP in the setting of the primary medical home. A comprehensive PPE should be performed every 2 to 3 years. The PPE should be scheduled immediately before the start of preseason. And current PPE intervals at high school and college level vary. Give everyone a little bit more time on that one. There we go with the answers there. And then that third question that we have, the 5th edition of the pre-participation physical exam has an increased focus on specific medical and musculoskeletal concerns for the female athlete. Which of the following is not one of the specific areas of concern? Bone and joint questions, nutritional concerns, menstrual history, or cardiovascular conditions? While everyone's submitting for that, I did see one additional question about Paulo Banchero and his history of hyperhidrosis. I actually have never had a case with a patient with problems with sweating. So, this is a great question, and I'd have to actually think about this a little bit more. Dr. Statuta, I don't know if you've had any history of this, and kind of if you've had any history with using supplementation to work at hyperhidrosis. Again, I have not seen this. If there's anyone on the phone who has dealt with this or on Zoom who has dealt with this, it'd be great to hear from you.
I have.
Okay.
I do. Oh, there's the answer.
There we go. Perfect.
All right. So I do see it. I know there are, and of course, I'm drawing a blank on this right now, what medications there are available. It can be pretty common. It can be isolated to the hands and the soles of the feet. It can also be just in the axillary regions. So there are types of antiperspirants that can be used, but it is pretty common, and I don't categorize it as a heat disorder. I just categorize it as hyperhidrosis. But it can be, oh my goodness, I wish I could think of this. If anybody in the audience can think of the treatment, but there are washes, there are soaps that can be used to help calm that down too. So,
yeah,
but it can be pretty challenging, especially for middle school, high school kids, and particularly female athletes get very self-conscious about that. So,
well, thank you for that. And this is definitely an area that
dry saw.
Okay, there we go.
Yeah.
This is an area that I will definitely be reading up on.
So Daphne, just as we wrap up, would you mind talking through just one last time, the question and the correct answer?
Oh, yes. So sorry about that. So for that first question, guys, so which of the following is not a goal? So the correct answer was disqualify athletes for conditions. So remember that the PPE is really not meant to disqualify, and it's pretty rare occasions where an athlete gets disqualified. Research has shown less than 3%. For that second question, so which one of the following is incorrect regarding the setting, timing, and frequency of the PPE? The PPE should actually be scheduled more like 6 weeks out from the beginning of preseason. So this would give you time if you identified any abnormalities that needed additional treatment or workup, it would give you time to do that prior to the athlete's start of the season. And for that third question, with regards to specific concerns for the female athlete, cardiovascular conditions was the one that was not a specific area of concern there. So.
Well, thank you, everybody. Thank you, Dr. Scott. We really, really appreciate you coming and sharing all your wisdom with us. For those of you out there, if you want to listen to this lecture again, it's going to be available on YouTube. And then please complete that evaluation that is in the chat. That's, again, very, very helpful to us. And if you have any further questions, please reach out to us by email, and we will then hopefully see you in 2 weeks. Thanks, everybody, and have a great night. Thanks, Dr. Scott.
Thank you for having me.
Thank you. Take care.